and greater professional satisfaction. This webinar is dedicated to triple-negative breast cancer. The theme has been chosen based on the uniqueness and the typicalities about triple-negative breast cancer. As the name goes, it's a lack of expression of the three markers, the two hormone receptors and the HER2 new. We know that this has been linked to the basal type of breast cancer and has been thought about as a surrogate for that. And we also understand that about 20 to 25%, broadly about 15 to 25% of the breast cancers are triple negative, and which goes to say that they lack those expressions. And other uniqueness about the entity is that there are two distinct age brackets. The younger women are associated with the BRCA1 and the basal type, and the older women associated more with the apocrine and the rarer triple negative and the normal like. Though it's a one disease entity, but it tends to be a heterogeneous disease with the subtyping and the subclassification based on the further biomarkers. Also, one of the unique factors is that the sensitivity to chemo lends an opportunity to treat this in the neoadjuvant setting in the early disease to affect a PCR and therefore attempt to get a better outcome for even the early TNBCs. Friends, there are many other nuances, many other unique features about triple negatives. They respond, they relapse within the first 3 to 5 years, do not relapse beyond that. And the recent interest about immunotherapies, PARP inhibitors, and the drug antibody conjugates have expanded the horizon and given us more treatment options, particularly in the metastatic setting. Apart from the cytotoxics dominated by the anthracycline, taxanes, eribulin, capecitabine. With that prelude, I come to the various presentations and draw your attention towards the program which we have lined up. And the program revolves around early disease and metastatic triple negative breast cancer. And in the early disease, we are discussing about the recent advances incorporating the immunotherapies, both evolumab as well as atezo, and also olaparib as part of the PARP inhibitors. And in the metastatic setting, many other newer therapies, as I said, including the antibody conjugates. We have a good number, that is about 390 registrations for this program. We are getting better month on month, and we hope that we continue to draw the traction and we come up with more novel and unique programs month on month. I thank Isai and particularly Arun, who has been very supportive for this program and allowing us to choose an academic agenda, absolutely focusing on the core area of recent development. Thank you so much. Back to you, Priyanshi, to continue the proceedings.
Thank you so much, sir, for the wonderful welcoming of the program. So let us begin with our first session. For that, I would like to welcome Dr. Shaina Goel. She's consultant in Department of Medical Oncology and Hematology from Medanta, and she's going to speak on ABRAVE phase 3 trial of adjuvant evolumab versus observation in patients with early TNBC with residual disease post neoadjuvant CT or at high risk after surgery and adjuvant CT. Thank you, and over to you, ma'am.
Thank you, thank you, Priyanshi. Thank you. So I'll be sharing my screen, and please confirm if my slides are visible.
Yes, ma'am, it is visible. You can do on the full screen mode.
Yeah. Thank you. A very good evening. I would like to thank the organizers and Dr. Ved sir for inviting me here for this webinar. And today I will be talking about this study that was presented.
Sorry to interrupt, ma'am. Could you please put your slide on slideshow mode?
It's not visible on slideshow mode. I've already put it on the slideshow mode.
No, ma'am.
Okay, how do I do that then? Or maybe you could share the slides and I could speak.
Okay, ma'am. That's okay. I'll do that.
Yeah, because I think it's due to some technical issue. It's not showing.
Okay, no problem. Just give me one moment. I'll share it from my end. Thank you.
Okay, shall I start? Is it now full screen?
Yes, ma'am. Please.
Okay. So a very good evening. So I will be talking about this ABRAVE trial, as mentioned. It's a phase 3 trial of using avelumab in the adjuvant setting for early triple-negative breast cancer who are at high risk either post-surgery and post-adjuvant chemo or with residual disease post-neoadjuvant chemo. So next slide, please. So as we know, triple negative breast cancer has the worst survival outcomes among all the breast cancer subtypes. And as mentioned by Dr. Wetzer, the achievement of pathological complete response has been the aim today with all the chemotherapy and newer agents, whatever we are trying in triple negative breast cancer, because now we know that achieving a PCR correlates with outcomes and prognosis in these patients. So neoadjuvant chemotherapy is a standard of care today for all clinically T1C or clinically node positive disease. And in triple negative breast cancer, we do not have, till recently, we did not have any targets, but it has an immunogenic environment which has shown the use of immunotherapy and the introduction of immunotherapy from metastatic TNBC to early triple negative breast cancer has been well shown by the Keynote 522 study. And here we are going to talk about another immune checkpoint inhibitor, which is avelumab, an anti-PD-L1 antibody. The investigators of ABRAVE trial wanted to look at the use of adjuvant immune checkpoint inhibitor in early triple negative breast cancer who are at high risk post either the residual disease post neoadjuvant therapy or high risk after surgery and adjuvant chemo. A point to be noted is at the time of study design, only chemotherapy was the standard of care for triple negative breast cancer, and there was no role of immune checkpoint inhibitors at that time in the early breast cancer. So with that, let's move forward. Next slide, please. This is a randomized phase 3 open label study. This was being conducted in around 70 centers in Europe. They have taken patients triple negative breast cancer who have previously completed locoregional and systemic therapy with curative intent. Prior use of either neoadjuvant or adjuvant setting anthracycline and taxane chemotherapy. Patients who had tissue for PD-L1 expression testing and performance status of 1 or less. These patients were randomized to use of avelumab 10 mg per kg Q2 weekly for a total of 1 year versus observation. And patients were stratified by the high-risk group. That is either the adjuvant therapy. In the adjuvant therapy, the included groups were pathologically node 2, N2 or N3 disease, or pathologically T2, N1, or pathologically T3, T4 with N0 and above. And the second high-risk group was post-neoadjuvant patients, post-neoadjuvant therapy. And these were the two subgroups among which they then stratified patient and analyzed further. In this study, adjuvant ET endocrine therapy was allowed for estrogen receptor 1 to 9%. Radiation therapy was allowed. Also, patients were allowed to receive capecitabine as adjuvant therapy in those who had residual invasive disease post-neoadjuvant. Unlike the trial Keynote 522 for pembrolizumab, where they did not really use adjuvant capecitabine. So follow-up assessment was done 3 times during the first year of therapy, and then every 4 months during second year, and then every 6 months. Co-primary endpoint were disease-free survival in the overall population and disease-free survival in the post-neoadjuvant population. Key secondary endpoint was the overall survival and DFS in PD-L1 positive patients. And then certain exploratory objectives were seen. Next slide, please. So coming to the baseline characteristics, which we can see from this table that they were well matched between the two groups. And the median age was around 51 years. As expected, the younger age group for triple negative breast cancers. Around 10% to 11% patients had a germline BRCA mutation. Among the adjuvant population, which comprised of only 83 patients, it was a smaller group. 50% was stage 2, 50% was stage 3. Among those who had received the post-neoadjuvant chemotherapy and with residual disease, which comprised of almost 85% of the study population, we can see the AJCC staging at the time of surgery is well balanced, and most of them had a YPT1N0 disease. They also checked into the residual cancer burden, and most of them had a score of 250% versus 41%. As I said, adjuvant capecitabine was allowed, but only around 25% patients in the avelumab arm and 18% patients in the observation arm had actually received it. So it was not received by all patients who had a residual disease. Next slide, please. So coming to the results, the primary endpoint, that was the 3-year disease-free survival. What they saw was that it was a 68% in the avelumab arm versus 63%, with an absolute difference of 5.1%. So this was much lesser to what they actually expected when they started the trial. The investigators wanted to look at a difference of around 13%, but this was only 5.1% and was not found to be statistically significant, with a p-value of 0.17. But interestingly, the secondary endpoint of 3-year overall survival was 84% versus 76%, absolute difference of 8.5%, and this was found to be statistically significant with a hazard ratio of 0.66. That is 34% reduction in the risk of death. Also, when they looked at 3-year distant disease-free survival, it was 75% versus 67%, absolute difference of 7.5. This was also found to be statistically significant. Looking into the second co-primary endpoint, which was the outcome in post-neoadjuvant population, the 3-year disease-free survival, this was 66.9 versus 60.7, absolute difference of 6.2%, again not found to be statistically significant. But we can see when they looked at the subgroup of post-neoadjuvant therapy residual disease patients, the absolute difference was slightly better than the overall intention to treat population. But again, it did not reach a statistical significance. So next slide, please. Coming to the safety analysis, they found that only 30%, so only 28% patient to be precise, actually discontinued avelumab. That is 72% patients completed 1 year of planned avelumab. And among these, there was a small group which stopped due to the adverse events. And immune-related adverse event was also seen in a small group of patients only. And we can see from the second table that the most common of them was hypothyroidism, around 13% patients with avelumab, followed by colitis, that is in 7.2%, and hyperthyroidism and increased transaminases, which was seen in 4.7% patients. Grade 3 adverse event was only seen in grade 3 or more was only seen in 1.3%. So overall, the safety profile was quite okay, and avelumab was well tolerated. So coming to the next slide, please. So coming to the conclusions and our take on this and how we can actually include this into our clinical practice, like we saw these patients of high risk triple negative breast cancer, when avelumab was added as adjuvant therapy, if there was a non-significant improvement seen in the three-year disease-free survival. However, a significant improvement was seen with 3-year overall survival and distant disease-free survival. So this is an interesting thing, that even though the DFS did not show improvement, overall survival showed a significant improvement. And though there is no definitive explanation given by the investigators on this, but probably due to the distant decrease in the distant recurrences, the overall survival was better. And they're also looking into other points which could be showing this difference. And we discussed already the overall survival that is significant. There is almost a 34% reduction in the risk of death. In terms of safety profile also, avelumab has been shown to be well tolerated. Now, how the one thing is that this is one of the positive relative, at least the overall survival was shown to be better, which we do consider an important outcome measure for a breast cancer patient. So this trial did show there was some overall survival improvement and a numerical DFS improvement. But if we look at other adjuvant immune checkpoint inhibitor trial like that for the atezolizumab, the Alexandra trial, that was negative. So this is one of the trials which is showing that it could probably add benefit to a small subgroup of patients which need to be identified, where adjuvant avelumab for 1 year could improve outcomes. What we can think of that small subgroup are those patients who, due to any reasons, have not received a neoadjuvant pembrolizumab, because as we know today with Keynote 522 data that use of neoadjuvant pembro plus chemo has become the standard of care, following which adjuvant pembro is continued for further 9 cycles. So avelumab could be considered for those patients who, due to either poor performance status, comorbidities, or maybe low burden disease, where the physician did not feel the need of using a immune checkpoint inhibitor in neoadjuvant setting, and after completion of chemotherapy they have a residual disease which we know would do relatively poorer compared to the patients who achieve PCR. These patients can be offered avelumab. Also, I feel that one more point is that this trial is telling us that those patients who achieve PCR post neoadjuvant therapy probably have done well. So probably that group of patients may not need adjuvant immune checkpoint inhibitor, and we can probably spare them with the toxicities of immunotherapy. So with the Keynote 522, all patients received pembro. So this also needs to be looked into further studies, which is actually an ongoing trial also, whether the patients who achieve PCR post neoadjuvant can be spared continuing further adjuvant IO. So I think this is an interesting paper study which has come out, and we do need more studies like this to answer further questions on using ICIs in TNBC and selecting the right group of patients. Thank you.
Thank you so much, ma'am, for such a great opening of a webinar. Going further, we have our next talk on NSABP B59 GBG 96 GeparDouze phase 3 trial of new adjuvant CT plus atezolizumab followed by adjuvant atezolizumab for stage 2 and 3 TNBC. And for that, I would like to invite Dr. Shaunak. He's consultant from Jawaharlal Nehru Cancer Hospital and Research Center. Thank you, and over to you, sir.
Hello, good evening. Thank you for the kind invite. I've been following this webinar series for quite some time, so finally being involved is a good opportunity for the learning and platform. So today I'll be speaking on GeparDouze. Can you see my screen?
Yes, sir, it is visible.
Yeah, I'll just.
Yes, sir.
Yeah.
Could you please put on slideshow mode?
Yes, it's on slideshow.
Okay.
So today I'll be speaking on the NSABP B59. That was the GeparDouze phase 3 trial on NACT plus atezo, followed by adjuvant atezo for stage 2 and 3 triple negative breast cancer. So the background is that we know that TNBC is a highly proliferative subtype of breast cancer, which has a high TMB, high tumor infiltrating lymphocytes, which makes this tumor type more susceptible for immunotherapy. And atezolizumab in their previous trials have been shown to improve PAT-CR rates in early TNBC when combined with NACT. We know that PAT-CR rates have an improvement in EFS and OS as the Keynote 522 showed, and significantly prolongs PFS in the metastatic setting when atezolizumab is added to nab-paclitaxel. And it can be safely combined with the standard of care chemotherapy, demonstrating a manageable adverse event profile. So the GeparDouze trial assessed whether the addition of atezolizumab to NACT followed by adjuvant atezolizumab could improve clinical outcomes for stage 2 and 3 TNBC. So it was a randomized phase 3 trial where TNBC patients that were T1C and node positive or T2 and T3 were included. The primary endpoint was event-free survival, and the key secondary endpoints analyzed was OS, PCR, and safety. So the trial gave atezolizumab plus paclitaxel carboplatin for 12 weeks, where paclitaxel was weekly for 80 mg per meter square and carboplatin was 3 weekly AUC 5, followed by atezolizumab plus the anthracycline AC or EC, which was either given in a dose dense or a 3 weekly format, and compared to placebo with paclicarbo followed by anthracycline cyclophosphamide. After the completion of the neoadjuvant phase, there was surgery followed by adjuvant atezolizumab versus placebo to complete 1 year of therapy. So the baseline characteristics were more or less equal in both the arms. Some things that do stand out is one, the nodal positivity rate. It was about 40% in both the arms. The primary tumor size, 1 to 3 centimeters were most of the patients, around 58%. And 41% of them had a tumor size of more than 3 centimeters. PDL1 positives or that were determined were only 36% of the total population. And AC anthracycline was given in a dose-dense format in most of the patients, in 63%. The other tumor characteristics that we need to analyze considering the TNBC and the immunotherapy use is the stromal TILs. So there were 1/3, almost 37% of patients had a stromal TILs on the baseline specimen of more than 30%, while the remaining had less than 30% TILs. The germline status is something that we talk about now. So 50% of patients are wild type for BRCA1 and 2 and PALB2. However, a large chunk of patients had a missing BRCA germline status. Almost 40% did not have their testing done. So I think this is one of the limitations of this trial, because in daily practice, we do consider BRCA testing for all TNBCs, and therefore our adjuvant therapies can change. So the primary endpoint, the 3-year EFS was 83.8% with placebo and 87.7% with atezolizumab. The 4-year EFS was also around 4% numerically better, but the hazard ratio was 0.8 and crossing unity, and therefore not significant. Although they did manage to complete delivery of the planned chemotherapy in 80% of patients, and this was at a median follow-up of 46.9 months. The first EFS events, the most commonly were the distant recurrences, whether we talk about placebo arm or the atezolizumab arm, and half of them were in the CNS. Contralateral breast cancers were low but equal in both the arms. If we analyze the EFS by subgroup, now whether the inclusion criteria whether the treating groups were the GBG or the NACBP, the intergroup difference was not significant. For nodal status, node positivity did show a better benefit with the addition of atezolizumab. And whether we gave 3 weekly or dose dense anthracycline, it did not make a difference. So this is what we have seen even in the Keynote 522, where they have uniformly used a 3 weekly schedule of anthracycline so as to match with the immunotherapy schedule. For the primary tumor size more than 3 centimeters, the intragroup difference was significant, but the P for interaction for the intergroup variation was not significant. So the addition of atezolizumab did not make a difference based on the PDL1 status. Again, we know PDL1 is a dynamic biomarker, probably not the best biomarker, not the ideal biomarker for immunotherapy select we have. However, when they use the TILS criteria of more than 30%, these were the patients that derived some benefit of the addition of atezolizumab, although the intergroup variation was not significant. In terms of PCR and overall survival, so the PAT-CR was numerically higher with the addition of atezolizumab, 63.3%, difference of 6.3%, and the p-value was significant. When you check the EFS, depending on whether a patient has attained PCR or not, that was equivalent in both the arms. So rather than the addition of atezolizumab making the difference, it is the attainment of PAT-CR that rather makes a difference. So even if a patient achieves PAT-CR without the use of immunotherapy, we are going to get an equivalent EFS. OS outcomes were not significant after a median follow-up of 46.6 months. The median was not reached, but the hazard was 0.86. Safety summary and causes of death. So so atezolizumab was relatively well tolerated. Serious adverse events were 5% higher in the atezolizumab arm compared to placebo. And factors leading to discontinuation for atezolizumab were in 21% of the population. There were an equivalent number of deaths. The cause of deaths were breast cancer associated. Adverse events causing deaths were equal in both the arms. So the investigators concluded that adding atezolizumab to the NACT followed by adjuvant atezolizumab did not significantly prolong an EFS. The 4-year EFS was numerically higher, but not statistically significant. It did increase the PAT-CR rate of 63 versus 57%, and the overall safety profile was consistent with those that have been previously observed with the use of immunotherapy plus chemotherapy. And the investigators concluded that although they did not meet the primary endpoint, it supports the need for translational research to identify potential biomarkers to define who may benefit from immunotherapy for TNBC. And so this is not a practice-changing trial as of date, especially with the robust data that we have from Keynote 522, where there is a significant EFS, OS, and a PCR benefit. But it is just food for thought. Thank you.
Thank you so much, Dr. Shaunak, for such an informative talk on GeparDouze. So moving ahead with our third talk, we have Dr. Pankaj Goyal. He's senior consultant from Rajiv Gandhi Cancer Institute, Delhi, and he's going to speak on 10-year follow-up with adjuvant olaparib in patients with GBRCA 1x2 muted HER2 negative early breast cancer.
Thanks a lot. Hope my screen is visible.
Yes, sir, it is perfectly visible.
Right. I'll just share the presentation.
Thank you, sir.
So thanks a lot for having me here for the talk, and we'll be having some discussion about the 10-year follow-up with adjuvant olaparib in patients with the germline BRCA mutated HER2 negative early breast cancer, the OlympiA trial. So we have seen that it had some positive results, but then we have to see that in the long run whether it really works or the benefit shades off when the time passes by. So we had this OlympiA trial with patient with HER2 negative hormone positive patient who were germline BRCA mutant stage 2 or 3 who had completed neoadjuvant or adjuvant chemotherapy have been subjected to olaparib versus placebo. So in the neoadjuvant group, we needed the patients who were not having the PCR, and if the patient had this adjuvant group, we had either node positive or size more than 2 centimeter. And CPS ECG score could also be checked if it should be more than 3. And patients should have completed adjuvant or neoadjuvant chemo, and then olaparib was recommended for 1 year versus placebo. And this covered hormone positive as well as TNBC patients. In hormone positive, patients who were on neoadjuvant therapy, they had this CPS EG score more than 3. So these were the baseline characteristics. 70% were BRCA positive, 28.3% BRCA negative, premenopausal 62%, postmenopausal 37.8%, and around 75% of the patient had mastectomy done. So these are the current analysis and the previous analysis given together. So we can just discuss it out that the chances patient with first IDF event in current analysis was 19.3%. The previous analysis had reported 14.5%. While placebo, they were much higher. So if you see the current one, the current analysis is 19.3 versus 28.2% in the placebo. The chance of distant recurrence also decrease. They remain as we had seen in the previous analysis. CNS recurrence 2.8% versus the placebo, which is 4.4%. And if we do not see the CNS recurrence, it was olaparib 8.7%, placebo 11.9%. So there were lesser regional recurrences and the distant recurrences as well. And if we see even the contralateral invasive breast cancer, they were less in the patients who were on olaparib. Olaparib, the ipsilateral recurrence was 1.2% as compared to 2.4% in the placebo. And second, primary non-breast malignancies, they were also somehow lesser in the olaparib, 2.2% versus 4% in the placebo arm. So difference in the DFS, if we see the 4-year IDFS rate difference in the 6-year IDFS difference. So 4-year IDFS difference of olaparib was 8.4%, and it has increased over this another 2 years, 6 years is 9.4%, and ratio is 0.65. So similarly, whether the patients were prior chemotherapy or new adjuvant or adjuvant, in both of these, the 6-year IDFS shows a hazard ratio of 0.657, which appears to be favorable. Then we had this subset analysis whether the patient will be benefited depending upon whether the patient has been exposed to platinum or not. In both these, we see whether platinum exposed or not. Both had a hazard ratio of 0.763 and 0.628, favoring the usage of olaparib. And HR positive as well as HR is hormone negative, the TNBC types, hazard ratio again we say it was 0.681, favoring olaparib. So so this 10-year update, if we see this olaparib versus placebo, it is still maintained 7.5 versus 7.8%. And similar to the previous discussion, we see that in the adjuvant, neoadjuvant, or irrespective of the platinum usage, hormone positive or negative, in all of them, we see the hazard ratios from 0.62 to around 0.745. And BRCA 1 and 2 both had benefited from this. So OS, if we see 4-year OS difference by percentage, it was 3.2% at 4 years. 6-year, 4.4%, it's even better. And starts for hazard ratio 0.72. And again, in the subset analysis, the prior platinum if has been exposed, then we see the quantum of OS benefit was not really significant, 0.979. But platinum naive, they had 0.653. And chemotherapy, irrespective of adjuvant, neoadjuvant, both had derived benefit. Hormone positive, hazard ratio 0.81, while in TNBC 0.713. So deaths, number of deaths we see in current analysis, in olaparib it was 11.6, while placebo it was 15.6. Deaths because of breast cancer were 10.2% versus 14% in placebo. Other malignancies were more or less comparable. So basically, breast cancer deaths, related deaths were lesser. So safety, we do not see any new safety signals with the prolonged usage, as we see that the percentage of this side effects are more or less same over these years. As far as this olaparib is concerned, if you see more chances of this side effects, I think we can just see some pneumonitis in 1 to 1.4%. New primary malignancies is around 2.9%. In current analysis, they are now 4%. And ovarian malignancy, which were hardly there, current analysis reports 1.5%. So not much of increase in the side effects with the years, the prolonged side effects of this. Then new breast and ovarian cancers on study premises, the bilateral mastectomy with pure randomization, the new breast and ovarian cancers, olaparib 36.8 and placebo was 35.1. These were bilateral mastectomy prior to randomization. And post randomization, we see that comparable number of patients underwent these surgeries: 34% in the olaparib arm and placebo 42%. And pregnancies were more or less comparable: 51% in the patients who underwent these breast surgeries, and most of them were full term. So the author concluded that even with the 10-year extended follow-up, we see the benefit of the olaparib was still maintained, and there were no new safety signals which were seen with olaparib. So with that, I'll conclude, and if there are any discussions, we can discuss.
Thank you so much, Dr. Pankaj. So we can discuss in the panel discussion.
Yeah, thank you.
Don't mind. Yeah. So I would like to invite our moderator, Dr. Amish Vora. He's head of medical oncology, director and co-founder of Hope Oncology Care Clinic from Delhi. And our panel discussion topic is current and future treatment strategies for metastatic TNBC. Thank you, and over to you, sir. So you can invite your panelist.
By the time Amish invites the panelists, Pankaj, if you are there, I must express my gratitude and a special thanks to you.
So,
And for taking up whatever it is,
yes, sir. Thank
say
you, sir.
that I can do it.
Sir.
Hats off. Thank you so much.
Thank you, sir. Thank you.
Thank you so much.
Thank you, sir. VETS's webinars are always interesting, and there is one new dimension which is being added today. So my slide is visible and I'm audible, na?
Yes, sir. Perfectly audible and visible.
Perfect. So we have panelists today is Dr. Pankaj Goyal, whom I see, Dr. Tarachand Gupta. Do we have Dr. Tarachand Gupta? Do we have Dr. Tarachand Gupta?
So he's joining in a while.
Okay. Then we have Dr. Wasim Abbas.
Yes, sir. He's also joining.
He's also joining. Dr. Varun Goyal.
Yes, sir. We have Dr. Varun and Dr. Shaina,
Dr.
ma'am.
Varun Goyal and Dr. Shaina Goyal. Okay. Right. So we have Dr. Wasim and Dr. Tarachand who are joining just now, right?
Yes, sir.
Okay, perfect. So when they join, just let me know so that I can involve them. Fine. I see Dr. Shaina. Dr. Pankaj, can I request you to switch on your video?
Sure, sir.
Amish, what is the fourth dimension?
So the fourth dimension is that apart from me and Dr. Wasim, we have only Goyals and Guptas in this panel.
So it will
And
be
sir,
BJP.
sir,
It
if
will
you
be
see
BJP panel.
last 10 years of unicorns in India, a majority of them are Goyals and Guptas, sir.
So they hold the patents
They hold the patents. Absolutely right, sir.
So we also have some hope.
Right. So I will, the discussion is current and the future management of metastatic breast cancer, that is triple negative breast cancer. I have 35 minutes and we will see how much we can cover. I like to cover at least the current management part so that all the attendees can, go home and mull over the thought process of that. So I have a case presentation. 77-year-old female. I would request all the panelists to give their answers in two scenarios. One, if they feel the patient is 77 years old, or if the patient is 57 years old, because the thought process will slightly differ. So this patient has chronic obstructive pulmonary disease for last 20 years. She is hypertensive, not so controlled, but no other comorbidities. There's a 2 months history of repeated hospitalizations for LRTI, repeated pneumonia, pneumonitis. CT chest showed lung lesions, and that's how the thought process started about the malignancy. And the pulmonologist asked for the PET scan. So PET scan showed lung lesions. There was a large left lower lobe mass also. Then there are bony lesions and incidental finding on the breast mass. Now, patient does not give history that she ever felt or palpated the breast lump. We did a biopsy from breast lesion and it turned out to be ER negative, PR negative, HER2 plus equivocal, and the FISH negative. The second opinion that patient took from AIMS, and they found that triple negative with HER2 is no expression at all. So I would like to start with Dr. Varun. We have Dr. Varun. Can we have your video on?
So he's joining in 1 minute. He just left and again he got some
Dr. Varun is
connectivity.
joining us
We
1
have
minute.
Dr. Wasim. We have Dr. Wasim.
Okay, Dr. Wasim is here. So I'll take
Yeah,
and once
yeah,
when we have Dr. Tarachand, we will ask Dr. Tarachand also. So Dr. Wasim, since you have just joined, did you go through the case or should I repeat?
So I assume there is a lung lesion, right? And it's kind of a metastatic TNBC,
No,
right?
so metastatic TNBC with lung, bony, and lymph node masses
Okay.
in a 77-year-old female. But the age does not matter, Dr. Wasim. Such patients, when they come to you, in your mind, are you now taking them as TNBC or are you taking them as HER2 low?
Okay, it was a HER2 low as well, right?
HER2 2 plus and FISH negative in one lab and HER2 0 in another lab. But we forget the another lab, HER2 0. Assuming this patient, first line metastatic breast cancer, comes to you with ER/PR negative and FISH negative for HER2 amplification. In your clinical practice, would you take these patients as HER2 low or would you take this as triple negative breast cancer?
I know that's a very challenging question. See, it
Don't
can be,
worry,
I think,
whenever we are not in unison, we will reach out to Ashok Vaid sir and he'll give the final answer.
I think we can look into both ways. I think it is TNBC, actually FISH negative, and what we have been practicing now till date, and now as it is HER2 2 plus, so it's a HER2 low as well. I would say yes, it is a HER2 low.
Okay, so HER2 low versus TNBC, not very sure based on today's current literature. Pankaj, what do you take this patient as in your clinical practice?
So in first line, I think I'm not very much confused. It's the treatment will remain same. So
Okay.
whether it's 0 or 1 plus, the treatment is going to remain the same. In second line, yes, it will matter.
So in your prescription, when you write, seen by Dr. Pankaj, you
Sir.
will write as TNBC or would you write as TNBC in the bracket HER2 low?
Sir, in first line, I'll be writing at TNBC. I will not
Only
be
TNBC.
pressing
Okay,
on that one.
perfect. Dr. Shaina, you agree? Dr. Wasim says he is not sure. Dr. Pankaj is very crystal clear that this is TNBC. Dr. Shaina?
Yeah, sir, I think I would also, for first line, go with what Dr. Pankaj sir is saying, that I would also just write it as a TNBC. But yes, I would be keeping in mind that HER2 low means it should be clearly visible so that whenever the next line comes, it should be
You
more.
do not miss out in on another two.
Yeah, yeah.
You do not miss out on the HER2.
Yeah.
Okay. Is anybody tempted to use NHER2 in the first line? Say, HER2 2 plus, you do to 2 labs and they FISH, the ratio is just borderline. Say one
Dr.
time.
Amish, Dr. Amish, yes, I am Dr.
Yes, Dr.
Tarachan.
Tarachan. Yes, please go ahead.
Uh, my take on will be like this: DV06 is upcoming now, and
Right.
where the HER2 low maybe in the first slide or not. And if the PDL1 is more than 10% and at baseline, then I may consider this
Tarachan
as
will
a
come to
TNBC.
PDL1. My question is,
Hello?
right now, are you writing in
Hello?
your prescription TNBC or
Yes.
HER2 low?
As of now, if you ask me that for HER2 low, this NHER2 is in second line, but as the data of the NHER2 is coming up day by day and that the drug is going blockbuster, so I would go for the as per the PDL1. If this is more than 10%, then I will go with the pembrolizumab plus
Right.
chemotherapy as a first
Correct.
line.
So
I'm considering
we
this as a
will, yes,
TNBC.
absolutely.
Otherwise, I will go for the NR2 if the DV06 says that as a first line it is good, then I will go with the NR2 if the PDL1 is not supporting the IU in that
Okay.
case.
Perfect. So, Ved sir, if you are there, right now,
Yeah,
tomorrow, if I have a patient, should I write in my prescription TNBC or should I write HR negative, HER2 low and move forward?
I think it's an evolutionary process, and we are in a phase of transition at the moment.
Right.
And as very rightly articulated by other colleagues here, that one should not lose the perspective that we are now dealing with an entity which has evolved. Though we are not going to choose the treatment right at this point in time, but I think the day is not far that this would bifurcate into a new entity altogether.
Perfect. I think all of us agree on that this is evolving and very soon we will try to change the way we look at this. So let me start with, do we have Dr.
So,
Varun now joined?
so Dr. Amish sir, so
Yes, sir.
we could not reach the conclusion, right?
No, the point is that right now, how I would look at it is that I will write that patient has ERPR negative, HER2 low, FISH negative. First line, as Dr. Pankaj said, to be treated on the guidelines of TNBC. And the second line onwards to look at the HER2 low treatment. That is what I would write. So that covers everything.
If the DV06 come positive, then in the first line HER2 low.
We'll have to see. We will ask Ved sir to have one more webinar and then we'll reach the conclusion at
Yeah,
that time.
okay.
Let's
That
move
is-
forward. Let's move forward. Yes, sir.
That will be the point when we would say we have arrived.
We have arrived, correct. Right. So, this is the NCCN guideline which I have, downloaded today so that we don't miss out on any new thing. And do we have Dr. Varun joined? Dr. Varun Goyal? I
No,
don't
sir,
see
he has
him.
not joined. Dr. Tarachand has joined.
Yes, Dr. Tarachan spoke twice, and I'm very well aware of that. Thank you. So let me come to Dr. Shaina. Dr. Shaina, the first line here says if the PDL1 CPS more than 10, regardless of germline BRCA mutation status. Okay. Now, and they have put it as a category 1 preferred. Now, do we have a subset analysis of the Pembro study, which established this as a category 1 recommendation, that yes, whether germline or no germline, pembrolizumab to be given in all the patients of PDL1 CPS more than or equal to 10? Dr. Shaina.
Yes, sir, if PDL1 CPS is 10 or more, overall, yes, the patient population did show benefit with using pembrolizumab plus chemotherapy. But however, with the data that we have for germline BRCA1-2 mutation, I think for all patients, we have to do a baseline germline BRCA mutation. And this group of patients could probably respond to the PARP inhibitors better. But as of
No,
now,
question is the first line treatment.
yeah,
Suppose assuming I get CPS PDL1 report in 1.5 days flat. If I request Ullas, he'll give me in a half a day. Okay. Then do I send germline right now or I can reserve it for future?
so we can reserve it for future. We are right in using IO in a patient with a PDL1 CPS more than 10, irrespective of the germline.
Okay, perfect. So that is what the guidelines say, and you exactly follow that, Dr. Shaina. Pankaj.
So, sir,
So-
actually, before answering you, I have another query that CPS is more than 10. Patient cannot afford Pembro. So, I give chemo alone or I give olaparib now?
So, Pankaj, I am the moderator. I will ask you that question very soon. So, Pankaj, my question to you is, if you see OlympiA study,
Yeah.
or if you see Talazoparib study, the median PFS, in fact, if you use in patients of chemo naive, is far better than the Pembro plus chemotherapy regimen or
Yes,
the study.
sir.
So why should we not do germline BRCA? See, this is an IO-free, chemo-free regimen you are giving upfront to these patients.
Yeah.
Okay. I have an issue with NCCN here because I have the similar issue in NCCN in HER2 positive where the TDM1 they have dropped down somewhere. There is no place for TDM1 now, which is not correct. In lung, crizotinib still is category 1. But here, so similarly here, based on one study, and that also a PDL1 more than 10, regardless of germline, they have said only and only chemo plus IO. Are we right in this?
I think so. Still, this remains a valid option because it's not that in the this olaparib study they have dropped out patients more than CPS 10.
Correct, absolutely.
So I am with you. I am with you that that should also be considered as option.
Okay, perfect. Ved sir, because I would want to move on the next point. So Ved sir, you agree on this point or you would say कि नहीं
No,
PDL1 CPS more than 10 मैं तो Pembro plus IO chemo ही दूंगा.
absolutely. I agree with the discussion. Bilkul.
You
Spot.
agree with the discussion. Okay, perfect. Dr. Tarachan, next point.
Yeah.
We have moved away from germline now. You know, we have liquid biopsy, we have somatic mutations, and I will show the liquid biopsy report very soon. Why only germline? Again, would you give olaparib in a somatic BRCA mutation or is it only germline? Because this guideline says only germline.
Yeah, as per the trial and as per the guidelines, that was suggestive of olaparib. But if we are seeing the same benefit in ovarian cancer and the somatic mutations also, even with the HRD only, not only the BRCA somatic. So I am just wondering that why we are not giving olaparib in a somatic mutation positive also. So my perspective is we should give, but there may be some medico-legal issues. That's why we are not using this somatic mutation positive
So if
cancer.
your patient on a FFPE tissue block, Dr. Tarachan gets a BRCA1 positive, but the germline is negative, and CPS is say less than 10 for the argument's sake,
Yeah,
would you give
yeah,
olaparib to that patient?
yeah. I
Or
think
would you not?
I will be tempted to give.
No, would you or would
If
you
the
not? Yes or no?
yes, I will give.
You would give. I also would give. Dr. Wasim, would you give PARP inhibitor in somatic mutations and not just germline?
In BRCA, I think I won't be giving actually. I think data is not that strong actually for somatic BRCA because I think we should not be comparing it with the CA ovary actually, probably.
Perfect. So Dr. Wasim is slave to data. I see that. Wherever the data is there, is there. I personally think somatic and germline, invariably, study after study, it has been shown that they both behave exactly the same in terms of pathology, pathogenicity of the cancer. So I personally think that I would give in a somatic BRCA also. In fact, I would give in CHEK2 and PALB2 also in these patients if they are not very keen on chemotherapy upfront. You have an option of chemo-free regimen. Ved sir, you switched on your video.
Yeah.
You wanted to say something.
I would only add that dash 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 after a very careful discussion with the patient and the family.
Absolutely right, sir. I only wanted to highlight that we follow NCCN every day. NCCN is not without its own caveat. Okay. So this patient's PDL1 is 5% by CPS. And Dr. Shaina,
Yes, sir.
what next? 77-year-old female, not comorbidities are there, but well preserved, can afford everything under the sun, actually can afford everything under the sun. And PDL1 CPS is 5%.
And germline somatic BRCA is negative. So I think
Germline is negative. Somatic, you ask me, I'll show you the report. But would you do NGS in all of your patients if they can afford?
So, sir, no, not really for all the patients. This patient, 77-year-old, having recurrent lung infections, looking at her performance status, maybe not a candidate for chemo. I could discuss the option of using NGS for her, but not per se for all patients.
Not for all. So 57-year-old female who's fit for chemotherapy, you would not look at the NGS.
No, I'm not in the first line. I want to see the germline
not in the
alone.
first line.
Yeah.
I think you are perfectly right, but this patient, I like to do NGS in all the patients who can afford, Dr. Shaina. This patient could afford the Garden 360, I did the Garden 360, and the tumor mutation burden was more than 10. In fact, it was 17. Germline BRCA1, BRCA2 was negative, not in this liquid biopsy, but in other sample. The liquid biopsy from Garden said PIK3CA, TP53, and AR amplification was pathogenic. The VAF was more than 5% in the liquid biopsy. And there's a single copy deletion in BRCA1, 2, CDK12, and CDKN2A. Okay. So there's a 123-page Garden 360 report. I have just summarized this. And trust me, this is the right this thing. So, Dr. Saina, what do you think of this report? Would you consider this patient as BRCA positive? There is a single copy deletion in BRCA1, 2, and CDK12 and CDKN2A.
Sir, I'm not sure. I think I would like to discuss it with my molecular pathologist.
Molecular oncologist, pathologist. And nowadays that's a standard. Dr. Tarachand and then Dr. Pankaj and then Ved sir.
Sir, two, three things are there. One, if I talk without NGS, then what is the harm in using toripalimab? That is having a very good data in PDL 1 to 10% in the triple negative breast cancer. One thing. Second thing, if the NGS is saying that the TMB is high, then every guideline is saying that if the MSI high or there is TMB high, then we can use the pembrolizumab also in IUK patients. So I will go with in both cases with the IU, either maybe toripalimab without NGS or with NGS, maybe the pembrolizumab.
With the pembrolizumab. Okay. Tarachand, I see you are driving or you are being driven?
Sir, you can say driving or not driving both, because I am driving in colony only.
Okay.
I have
Then it's okay. Then it's
driving
okay.
10 years, 15
Otherwise
years
it's
back,
not fair practice. Yes. So then it's okay, Tarachand. Perfect. Pankaj,
yeah.
do you take this as BRCA1, BRCA2 positive? Let's go straight to the answer.
So, see, one thing is that I'll have to again discuss with the molecular guy. And before jumping on these reports in first line, I prefer that I start this patient on chemotherapy, which I know it will work, single agent Pacli, and then go for these which might work.
Okay, perfect. I think I'll move forward. I discussed with molecular oncologist, and they said there's a single copy of deletion in these 4. They are not pathogenic, likely not to be pathogenic. They are not, probably they are a bystander effect, and take as a PIK3CA and TP53 are as the driver mutations. So I took them as a driver mutation and moved forward. Okay.
Amish, let me come back.
Sir, sorry.
So this is, let's go back to the profiling. So the older women are less likely to have a germline BRCA positive.
Correct.
So okay. The younger women are likely to be. So one point is corroborated here. Her cancer is basically the main driver will be TP53. It's the defect is in the protector of the genome.
Correct, sir.
That's the problem. And we are finding TP53, lot of patients who are not responding to any therapies are the ones who are harboring TP53.
So you have stole my mind thought process.
Be beware, be careful. This patient is going to be
sir, you are absolutely right. I'm mad about TP53. Half of patients with NGS report come with TP53, and in elderly patients, retinoblastoma, RB gene loss also. Right. And these are the tumor suppressors which have lost their function, and nothing much is going to work in these patients.
Absolutely.
Perfect. So we covered that. I just wanted to say Keynote 355, we have this study and we have OlympiA. In fact, I again wanted to highlight to all the people, if you have a germline BRCA positive and PD-L1 more than 10, please understand, don't remove the option of olaparib, because you have the ORR and you have the hazard ratio of PSS, which is quite significant. Okay. So patient was planned for chemotherapy. No IO, no PAP. Patient took 3 opinions, and 1 opinion was from the Premier Institute of India. They said PDL1 not more than 10%, no IO, only chemotherapy, and that's what it was. So Pankaj and then Wasim. Pankaj, I see you on my screen. You also talked about the chemotherapy. Between nab-paclitaxel, capecitabine, and eribulin, what would you choose?
The first line, I'll prefer nab-paclitaxel.
Nab-paclitaxel. Wasim?
Yeah, same nab-paclitaxel. Agree with
nab-paclitaxel. Okay, Wasim, coming to you, Capecitabine is an oral drug, and we all love capecitabine. Okay. So why subject patient? I'm sure you would give weekly nab-paclitaxel, right?
Definitely.
Every week in the daycare, every this CBC every week, every 6th day CBC, then 77 years में grafil देने का. Do we have any head-to-head comparison or category 1 comparison where nab-paclitaxel is better than capecitabine in the first-line metastatic breast cancer?
No, I agree. You can give capecitabine. I just am asking about personal preference because I have
You're
been
asking
giving.
of personal preference. Okay. Dr. Tarachan, just pick one of the three.
Yes, if I have to choose one of them three, then yes, I will not go with a weekly regimen in a metastatic setting. But thing is, why we are choosing nab-paclitaxel over the conventional paclitaxel when we can give an lower dose and can avoid the neuropathy that is more with the nab regimen. So
Okay.
and that can be given every 3 weeks. And yes, of course, paclitaxel in this age group doesn't need any pacgrafil or grafil, and that can worsen the neuropathy or any myalgia also. So from my point of view, I will and I use only the paclitaxel in this setting, only the conventional paclitaxel single agent.
Okay. Dr. Shaina, paclitaxel or capecitabine?
Sir, I would prefer nab-paclitaxel. I think with older age groups, sometimes using capecitabine, especially full dose, is very difficult. The diarrhea, the mucositis could be worse. So I would prefer a weekly nab-paclitaxel regimen. And I think there is a data of comparison. I don't really remember, but I remember reading up nab-pacli versus capecitabine. There is some study.
There is a
Actually,
study, but
have
it's not
been
a phase
shown
3
to.
study. And Dr. Shaina, we have a phase 3 study where eribulin in the first line or second line was found to be superior in terms of overall survival to capecitabine. My idea of keeping these three options is that nab-paclitaxel is a preferred regimen to go to. We all do that. Capecitabine is not a bad option, which we don't forget. And eribulin, we don't need to reserve for the second line, as the EMBRACE study showed us. Now we have a phase 3 data where eribulin was found to be superior to capecitabine. So what I'm trying to say that eribulin also can be your option in this particular patient. Okay. Patient opted for capecitabine oral, refused for intravenous chemotherapy. Patient uncontrolled COPD and hypertension, 2D echo borderline, LVF of 45% and GLSS was minus 13%. Okay, so Shaina, since I see on my screen, would you replace capecitabine with S1, assuming patient says no nab-paclitaxel, no eribulin, capecitabine, but with this echo you say, okay, S1 first line treatment.
So I don't think we have enough evidence to use S1 as of now in the first line setting, but I really won't. I would probably go with capecitabine and keep it
With
not.
ejection fraction of 45%, GLS minus 13 in a COPD patient, 77-year-old Shaina,
So
you are
that's
very
why
brave.
weekly
You are very
nab-paclitaxel
brave.
is better.
So patient refusing
Convincing
for
the patient
intravenous.
for a
See, we are talking a scientific aspect here, Dr. Shaina, that assuming
yeah.
nab-paclitaxel is not an option, capecitabine is an option, and you want to replace with capecitabine with S1 today in 2025, can we? Where, sir?
Yeah, we can replace.
We can.
So,
Where, sir?
Amish, my point is partly linked to this patient and also to the benefit of the postgraduates, students
Ji,
who
sir.
are on the program. Historically, how have we chosen drugs for breast cancer? And this is a very elegant choice and an elegant way of choosing drugs. Single agent activity, more than 50%. Historically, anthracyclines, taxanes, vinorelbine, and then eribulin got added to that. These are the four classes of drugs which have had single agent activity. The rest, everything, Y5FU fell off, FAC, 10-15% activity. Cyclophosphamide doesn't come in the elite class, but it
Correct.
works alongside anthracyclines. And of course, not to talk of the targeted drugs. This is only for the benefit of the postgraduates.
Absolutely, absolutely. So, Dr. Shaina, I also tried to search. We have in ASCO 2013, there's an abstract formation, but it's a phase 3 data where they have 142 patients study, where they found that capecitabine and S1 in a metastatic breast cancer are equal. some numerical advantage of capecitabine over S1 is there on OS, but statistically not significant in either of these things. But S1 had less side effects. So Japanese people believe that it is superior to capecitabine because it has less side effects and better tolerated. S1, the cardiac toxicity ranges to 0.8 to 0.9%. And the capecitabine, the cardiac toxicity ranges from 4% to 8% in various studies. Patient is 77 with ejection fraction. Yes, Tarachan, I'll come to with ejection fraction of 45% with uncontrolled COPD. With this data, I am more than happy to write S1. I wrote S1. Patient went to again Premier Institute, which is next to me, and they said, no activity of S1. You go back to capecitabine. I'm just sharing you the story. Dr. Tarachan, we have only 8 minutes now.
I mean, sure. One thing is, what is the harm in using X7Y7 protocol for the capecitabine to reduce the toxicities?
We can use that. The dose of capecitabine is not directly correlated with the cardiotoxicity or even hand-foot syndrome. That is what my understanding is. If I have not seen a study that these two side effects are dose-related. It can happen in any patient. Yes, we have now our AIMS own study, Dr. Atul Batra, where if we use the Volini gel in hands and feet, we can reduce the hand-foot syndrome. But trust me, I have seen enough cardiotoxicity on capecitabine as much as I have seen on 5-FU. And this is a very, very tricky situation. And that's why I believe with this data and with the data on stomach and colon cancer, S1 can be replaced.
So, but none of them was actually an absolute contraindication to use capecitabine in this patient. So, like Dr. Tarachan said, a modified dose of capecitabine would also be the right
one thing, and
I'm sure patient must have gone to both of you for the opinion. Patient came back to me and said कि sir, Dr. Shaina ma'am ने बोला है capecitabine देना है तो सिर्फ capecitabine ही हमको चाहिए. So me poor fellow changed from S1 to capecitabine. Patient could not tolerate capecitabine, GI symptoms, and there was extreme weakness. I requested patients that let me give you
because I did not find any toxicity with X7Y7.
Agreed. See, I believe in chemo-free regimen, in intravenous chemo-free in a 77-year-old patient, more than, they coming every week. Trust me, the quality of life is not so good as we think it is good. Although patient was 12 weekly dose. Wait, Tarachan, let me complete this slide and I'll come back to you. 12 weekly doses of nab-paclitaxel was given. There was an extremely good improvement in symptoms. Clinical response was there. Patient continued on the same. After 15 doses, there was a sudden weight loss, LFT deterioration, and the PET-CT showed there is a liver lesions and there was a progression in the disease. So next what? Next what is Tarachan? You have reached home, I can see. Please.
Yes, sir. Yes, sir. Yeah, I am at home.
So Tarachan, now
Hello?
next what?
Yeah.
Would you, patient has received capecitabine, could not tolerate, patient has received nab-paclitaxel. After 15 doses, after initial response, has progression in the liver.
So we have a regimen with us for the TNBC, AC regimen or EC regimen other than Gemcarbo and Binorelvin we are having. So we can use either of these. And Eribulin, if FDA not used, then we can use. Because after the third, fourth line, triple negative breast cancer, only PFS benefits are there. There is not causing any OS benefit.
That is not causing any. Okay. So Tarachan, I hear you. Let me go to Dr. Wasim. Dr. Wasim, this patient is your patient and can afford anything under the sun. Would you like to do the repeat biopsy in this patient?
I think probably no. I think we need to shift to the second line. I think we have done, like, it has been 6 months since we have done a repeat biopsy, right? Just we have a first biopsy.
Right.
I don't think it will change much actually.
It will not change much. Perfect. I still did the liver biopsy because this is a new lesion, one. And second thing is, as I said, since patient could afford, I like to learn from these patients for the next patients also. So I did a repeat liver biopsy and it was ERPR negative and HER2 low. 2 different labs I checked. Both the lab sets के डॉक्टर बोल रहा at least 1+ तो है ही है. If not 0, if not 2+, 1+ है ही है. So now we have a HER2 low, which is from 3 different labs. ERPR still remains negative. assuming patient can tolerate both sacituzumab govitecan and trastuzumab deruxtecan. So let me start with Pankaj and then Wasim. Which one would you prefer between the two? Or if you give one first and then second, or first, then chemotherapy and then second?
No, I think sir, both are good options. TDX3 or sacituzumab, but we do not have any experience with sacituzumab, and it's supposedly a more toxic drug. So I
Correct.
think TDXDB will be a better tolerable drug, and we are having experience with this drug. So I'll probably use TDXD now.
Destiny 04, Pankaj, there were 90% of the patients who were HR positive.
Yeah.
They still have not given us the graph of HR negative.
Mm-hmm.
There is just 2 lines mentioned in the paper. I'll read out those 2 lines because I remember them. So this patient is HR negative. And we have a wealth of data with sacituzumab govitecan in triple negative, assuming this is 1+ and triple negative. So let me ask you again, sacituzumab govitecan versus TDXD in terms of the wealth of data. Pankaj first and then Wasim next.
The data is okay, but then this will be driven by the her 1+ or whatever her low. So I'll still stick to TDXD.
Still stick to TDXD with uncontrolled COPD. Wasim, 12% ILD का 20% हो जाएगा, मेरी जान ले लेगा patient. What would you give? What would you use?
Yeah, I think he is too unfit to receive any drug probably.
That was honest.
assuming this patient is a 60-year-old but uncontrolled COPD. Let's assume that.
Yeah, I agree. I think being a metastatic disease, I think I would prefer biomarker-driven therapy, probably TDX.
Okay, TDXD. Okay, perfect. Dr. Tarachan, just one. SG or TDXD?
TDXD.
TDXD. Dr. Shaina?
So I think lung function would be an important decision maker here, because if a patient has COPD, I would probably get a baseline HRCT or get a PFT also. If probably get the respiratory physicians involved, because the risk of ILD with TDXD is significant, and that would be an important decision maker for me.
Absolutely. I completely agree with you, Dr. Shaina. Ved, sir, since you give your comment, I also would like to ask you to answer the second last and the last bullet point.
So, Amish, could we outline the objectives of treatment and the goals of treatment for this patient for the benefit of the trainees and the young oncologists who are on the panel?
There is going to be a palliative treatment. That is the first thing. Intent is palliative. And in that palliative intent, the quality of life is the first thing. And second thing is, if we can achieve quality of life, then the quantity of life.
And especially the patient is progressed within 6 months of the previous treatment.
Absolutely right. After the 15th dose of nab-paclitaxel, patient has progressed, because as you said, PIK3CA and TP53 will not allow any drug to act beyond 3 months. Right. So, Ved, sir, would you give first ADC and then second ADC? Or you would say that one is the only enough?
No, Amish, I think it's a wide open discussion, but given the scenario, I could hear that she's got an uncontrolled COPD and runs a risk of ILD. As it is with a normal lung, it's 10 to 12%. And now you're going to be using a drug in the background of COPD. So one could expect anything out of
anything out of that. So sacituzumab govitecan, the curves on the right, and Destiny Breast 04, the curves are same.
One question, sir.
Yes, Tarachan, I have 3 minutes. Otherwise, then
sir,
Dr.
one point
is going to throw me out.
One point was highlighted, that COPD, and but just asking that in how, other than trial, that is a different thing. And how many patients of your patients are on TDXD have you seen ILD?
देख मैं दिखता हूँ अमीरों का डॉक्टर, पर मैं हूँ नहीं, मेरे पास उतने एनहर्टू के पेशेंट नहीं है.
No,
but I tell you, Tarachan, that first
may I go to bed, sir?
of
May I go
N-HER2.
to bed, sir, for this?
No, none of us have treated enough number of patients, because the numbers statistics would catch up with you.
Absolutely.
First 20 you may not have anyone. 21st and 22nd patient may ruin your statistics altogether.
My first 2 patients, sir, has ILD. biopsy proven ILD of Enhertu. Maybe my luck is not my 21st and 22nd patients were my first and second.
Yeah, as I said, you might land into trouble with the anytime.
And both normal PFT. Forget about CT and X-ray was normal. PFT was normal. Anyway,
I can share with you the SG, whatever we have used, is not as terrible a drug. It's not as terrible.
Right, sir.
Yeah.
I have used SG in around, I think, 4 patients, and 1 could not tolerate, the 3 could tolerate, and that 1 is here, which I am discussing. So this particular patient, what I wanted to say that trastuzumab deruxtecan and SG both have similar curves, if you see. So which one would you select first? The question of a debate. But there's a very beautiful article in the Target Oncology, Double Trouble for Breast Cancer. This was in July 23, 2024. I'm not going to ask this question because I'm run out of my time.
Amish, we have run out of time now.
Yes. So this is my second last slide before the thank you slide, sir. So double trouble means there are 5 centers who collected their data of 83 patients who received both the ADCs, one after other. What they found was whether you give SG followed by TDXT or vice versa, the PFS remains the same in majority of the patients. In some exceptions are there, PFS1 was shorter than PFS2. The idea of saying this was the author said you should explore giving both one by one. Intervening chemotherapy does not matter. So this was what, there's a very interesting I found, and I request everyone to go through that. So this patient I give SG and did not respond. Last was TMB more than 10, third line. Pembrolizumab, अब तो हम छाती ठोक के दे सकते हैं, but first line we could not give. That is what I wanted to say. And I thank you, Ved sir, for giving me this opportunity. And I request sir to keep involving us so that we also learn from each other. Thank you.
Very, very gracious.
Thank you, Ved sir. Thank you. Thank you, Ved sir.
Very gracious of you, everyone. And so it's been a great evening. Great learning out the entire exercise. And I thank Mice Ideas, Priyanshi, Rajesh for creating this platform again and again. And Isai, as I said in the beginning, we had 210 live attendees, and which gives us a lot of confidence and a lot of courage to move on. My special thanks to those attendees who took out time, equally to the speakers, panelists, Amish, and Pankaj, especially to you for taking up the job at the last moment. And we hope to see you soon enough with a new seminar, new webinar, and hopefully with an international speaker next time in the first week of Feb on hopefully a topic from the gastrointestinal malignancies. Thank you so much. Good night. Take care. Stay safe.
Thank you, sir. Thank you.
Thank you, sir. Thank you, sir.